So I'm Theresa Joyce, and he has asked me to give a quick introduction to myself. I'm a clinical psychologist by background and spent many years in the NHS running psychology and specialist challenging behaviour service teams. I also did some work on safeguarding for the trust that I was with. I left the NHS and then after a while went to the CQC and I was their professional advisor on learning disabilities, at which point I got very involved towards the end of my time there, in the review of segregation, seclusion and restraint that the CQC undertook. And I learned a lot from that, and some of that I'm going to share with you today. Currently, I'm working independently. I'm doing some work with the Challenging Behaviour Foundation, and I also work as an expert witness in the Court of Protection, often writing reports on issues to do with how to support people with challenging behaviour, either should they be in hospital or shouldn't they, what sort of service they need in the community. I'll stop there. I'll get on with this. What I'm hoping for today is that we can have a chance to have a conversation and a discussion about what's going on in hospitals specifically, though we obviously need to think about the community, that's preventing people that we know are in hospital, that's preventing them from getting out. And I'm going to, I have a problem, my screen isn't moving.
Don't panic. Oh, there you go.
I panicked, it's moved, it just stuck. I've put this quote up and said, there's no such thing as a dysfunctional organisation because every organisation is perfectly aligned to achieve the results it gets. And we're often told, and a lot of reports say, the system needs changing. We need a massive overhaul of the system. There's something wrong with the system. That's what's going wrong. And I think it's important to remember this quote because actually what it's saying is, it's not saying that people are maliciously or perversely trying to do something to stop people getting out of hospital, but people work within the system and have a role within the system. And their role may not require them to prioritise doing the thing that we all think is important at this point in time. So if you work in finance, you don't go to work every day thinking, I've got to get X out of hospital. Your priority is to think, how do I make the books balance? Has X paid the bill? Are we overspending? Similarly, if you're a ward manager, one of your priorities will be to get X out of hospital, but it may at any point become, actually, is my ward running? Have I got enough staff? Are they doing the right thing? Is there a ward rep? A whole host of other things that the organisation requires of you will overtake you. And I want to remind us of why we're here in a sense, because the UN Convention on the Rights of Persons with Disabilities still works for us. We're not resolved from that yet. And it actually does say that people with disabilities have the opportunity to choose their place of residence and where and with whom they live on an equal basis with others and are not obliged to live in a particular living arrangement. And I think we all know that that doesn't always hold true for people with learning disabilities. And again, it can be very difficult to deliver. But I will say that when people are in hospital and detained under the Mental Health Act, in a sense, the right to do that becomes curtailed, certainly while they're in hospital. And when they leave hospital, they don't always get the choice that we think they should. And that's for all sorts of reasons and all sorts of pressures within the system. When I was in the CQC, I gave evidence at a number of tribunals where providers were planning on building quite large-scale services for people with autism and people with learning disabilities that just did not meet the requirements of a choice in the community. And the reason was usually money, but actually money can be used creatively. And often for the people we were talking about, it would have been cheaper to just set up an ordinary house rather than a large-scale institution. So there's a lot of things that go on that there are a lot of reasons given for, but actually, if we think about it a bit more clearly, we might be able to see our way through. And I want to remind us of real people at the heart of this, actually, and I'm sure most of you, if not all of you, have heard of Bethanys and know her story. So the story here, she lives in a bleak room measuring 12 by 10 with a plastic chair and mattress. Meals are passed through a hatch in a steel door. When her father visits, he's an amazing man, he kneels down to speak through the grill. If he telephones, the handset is held out towards the inmate by a staff member. When she self-harms, shoving part of a pen into her arm, it may be a while before it's removed because of the danger to staff. Is this some murderous psychopathic lifer? No, it's Bethanys, a girl of 17 with autism, in a psychiatric unit privately run at a hospital in Northampton. And importantly, it's 4 months since a professional assessment accepted, not for the first time, that her needs are not met in this setting, the tiny space poetically called seclusion. And that was Bethanys' life for a number of years. And the picture is of St Andrews. And we have more recently patient A, who was admitted to hospital 4 or 5 years ago. He's now 24. He lives alone in a 423 square foot apartment. I have to say, if I was going to rent an apartment, I don't think I'd rent that one, but that's just a personal view. He's got 24-hour CCTV monitoring and meals again delivered through a hatch. Nicola, his mum, says he had a typical childhood up until around the age of 12, diagnosed autistic age 7, then later with Tourette's and a learning disability. Locked away from the world, no physical contact with anyone. His meals to be pushed through a tiny gap in the bottom of the hatch is awful. People wouldn't treat an animal that way, and I feel that his care is worse than being in prison. He has challenges, but is a loving and caring person who needs stimulation and support, remembering the person behind the challenges. He's getting nothing at present. I can't even hold his hand or hug him because of the conditions he's kept in. And I think we all have to ask ourselves, why is this happening on our watch? Why is this going on in the services that we know about or work in? What are the barriers that are going on? What are the barriers that are preventing him from being able to move out of there to a better life? So to think about this, I think it's always useful to have a few facts and figures. And the people we're talking about are, there are 2,085 inpatients. This is November last year. And 1,095 are detained under Section 2 or 3 of the Mental Health Act, which means they're detained for assessment or treatment. They're not detained under a forensic section. They don't need a Ministry of Justice order to allow them to go. So let's just think, if we think about how we're going to concentrate on the future, we may want to concentrate first on the 1,095. That is not to say the 2,085 are not equally an issue. Of that 1,095, 460, that's nearly half, have been in hospital for more than 2 years, and an additional 190 between 1 and 2 years. So what treatment are people getting that requires a hospital stay of that length of time? And what is the hospital delivering? What are the hospital staff, the hospital organisation, the system delivering? Of the 2,085, and that therefore includes the forensic Part 3 sections, 190 had a delayed discharge due to lack of community provision. They had a plan in place and there was no community provision available. That's actually quite a small number. And I think we need to remember that, because it's always what we're told. You can't leave because there's nowhere for them to go. There was active treatment in place for 655 with the discharge plan in place. And there were 930 who had an active treatment and no discharge plan in place, and 275 we just don't know. So I think this tells a story about how actively we are really, as a system, if you like, because I'm part of it too, pursuing discharge for people who are in hospital. And I also want to make clear that actually I think hospital admission is sometimes totally appropriate. I wouldn't want to deny people the chance or the right to be treated in hospital for a mental illness, because it can be really helpful, and there are some brilliant people working in some brilliant services. So I'm talking about the much smaller group of people for whom we're having significant difficulty in making life better. In terms of discharge plans agreed, in the numbers that have been agreed, Commissioner had agreed 745, the clinical team of the provider 740, the community team 680. Well, I would have thought the community team should agree them all, exactly the same as the commissioner and the provider clinical team. And similarly, the family who'd agreed 560. And where were they going? Mainly the community, though 195 were going to another hospital, which often means going up a level of security. That could mean going down. So we need to think about that group. And for the care and treatment reviews, 630 had had no review for more than 6 months, which is quite a long time not to have your care reviewed. Excuse me, coughing, sorry. Now, there have been a number of recent reviews, and I just want to briefly talk about them just to remind ourselves. There was the CQC review into restrained seclusion, long-term segregation, which I mentioned. Then there was the Department of Health and Social Care review into the treatment of autistic people. They took evidence, the committee took evidence, and that was published last year. And then Baroness Hollins was asked to set up an oversight panel to look at the needs of people who again were stuck in very long-term segregation. And that again reported last year. And all of them came up with findings and recommendations that I think none of us will be surprised at because we know it. There were poor quality of care in hospitals, lack of assessment, treatment, etc. Poor discharge planning, which I think the numbers support. Funding streams were complex, which I think we can all agree. There was a lack of development of good community services, a lack of skills in staff, and a lack of focused commissioning. Now that we all know that all of these things are to some extent or lesser extent true in different parts of the country, but it's not enough just to say it, is it? We really have to think about what that means. And they said that problems with the overall system need resolving. But my thinking about this as I've gone around hospital after hospital was, what about the problems at the level of the individual patient? What's going on for them? What's the system doing that we might be able to act on? So as part of the review, I looked at care plans of people in hospital and also some community. And yeah, it was as part of the report, but I think it's worth noting it and thinking about it. When we looked at the plans, we had a structure and a format to look at them, helped by the PBS Academy. And we found that plans were often generic and not aimed at meeting individual needs. So you could find similar things in plans across, being repeated. People weren't getting the right assessments to inform care plans, and therefore they weren't getting therapeutic input. A number of people were autistic, and there was no sensory assessment. Communication assessments might have come from a previous placement but weren't redone when they moved. Assessments didn't seem to be a dynamic document, learning from what people were doing while they were in hospital. It seemed to be, it's done, I've ticked the box. We found shockingly that physical health needs were often not properly assessed and often not considered as a possible factor in a person's distress. There was one care plan which said, if any physical health needs, yes, he has a back condition, which his back is bent, it often causes him pain. But there was no mention of that as possible factor in the fact that his behaviour could sometimes become challenging. It was just over there somewhere. Okay, most people had a named PBS plan. It was called a PBS plan, but the quality was often poor. It was really mainly reactive strategies. There was often a lack of functional assessment. There was a real lack of skills teaching and a lack of relevant therapeutic activities. And I have to say on a couple of plans, when you looked at functional assessment, they described the behaviours as a group, and then all the behaviours had all the functions. So it was quite hard to determine what you do in any specific situation if X did Y, because it was all quite generic. Again, I'm not saying every plan is like this, but we need to be alert that some of them might be and be thinking about if they are. As I said, autistic people didn't always have sensory communications or an autism assessment, actually. Staff didn't always know what the PBS plan said. I went to one ward and I said, can you show me the PBS plan? And they said, oh, we don't have that on the ward. Psychology do that. It's in their office. So I thought, oh, okay. And then there's the readiness model, which I think we could all start talking about and we all know about. But actually currently, the model of getting discharged from hospital is that you're better, you're well enough to leave. And so in a sense, somehow people have got to be ready to leave. They've got to show that they're ready to go. And I think we need to be saying, no, we don't expect them to be ready to go, in inverted commas. We don't expect them to stop doing all the things that were distressing them in the first place. What we do is we make the community ready. We know them well enough to be able to move them as they are. And then when they're there in a better environment, we'll start working on all the things that are causing them distress and all the things they've learned in the past that's functional, which may not be functional for them. Just to remind the Department of Health report, I've quoted myself here, but hey, why not? We have a lot of reporting systems, a lot of policy and guidance. What we need is a situation where we make sure that people can be discharged. As I said just to you, I have a concern about a discharge model that says they're not ready for discharge. The issue is they will never be ready for discharge while they're in a unit that's toxic to their health. And Sheila Hollins said, very few have had any formulation. In other words, they have not had a multidisciplinary assessment. They didn't have a treatment plan based on a multidisciplinary assessment. Because most of them, and these were people in segregation, were there because of autism or a learning disability, there was no obvious point for them to be discharged. For most of them, if they were diagnosed as on the autistic spectrum, there still may not have been any expertise in autism in the unit. For many who were suspected to be autistic people, no autism assessment was planned. So we need to think about that, I think, in terms of how we approach what we do when we work with people in hospital settings. And I'll come back to it later. When we think about issues in community provision, and this is the one that actually gets most headline, if you like, this is the one that's most frequently talked about in terms of this is the reason why people aren't discharged. And I'm not saying that there isn't truth in that. There are acknowledged difficulties in developing good quality community provision, but actually delayed discharge is a relatively small proportion of those in hospital. And it does require consideration of funding flows and how it can be improved. And maybe we do need to start having more detailed person-centered conversations about that. And I recognise there are difficulties in commissioning appropriate models and housing. And if there are commissioners in the audience, then I think you have a really difficult job and you have a lot of pressure to often targets are getting people out rather than building the right thing. And we need to be joining together, if you like a coalition saying, no, we're not going to do that, we're going to do this. So maybe some more collaborative work on these issues would be helpful. And it also requires a skilled and motivated workforce with good specialist support. And I think that is really variable, both within providers and across the country in terms of health and social care support. And I think some services are brilliant, but I've certainly come across some services where people were much more frightened and worried about doing this stuff because they didn't think they had the skills. Again, it requires providers to develop housing that optimizes people's choices and autonomy. And actually, that's much more likely to make them able to stay out of hospital rather than have to return. And again, discharge plans. And I think we could all think quite carefully about the discharge plans that we see that reflect individual needs. And that's based on a detailed assessment. So it's not a, and I know it never would be, but actually it requires quite detailed and careful assessment about what the person needs, what their staffing requirements are. And actually, and these are really integral to the development of the community service. It's better not to find a house and fit the person in it. It's better to think about the person. And we know this theoretically, but actually it's how we do it in practice across the bit of the system where that individual is. And actually, I think it requires discharge plans to be reviewed. And detailed service specs could be sent to commissioners and followed up consistently. We need to ask ourselves, are we really pushing for this? Is it consistent follow-up? Are we really setting goals? Are we really, or do we say, yes, we've done that, but we can stop for a while and breathe? So in terms of barriers to improvement, again, I'm going to have to move I can't read my own slides now, sorry. Barriers to a focus on discharge. We need to support by staff for making, if you want people to choose something differently, then you have to be able to support them to enable them to do that. And the things that will make it harder for them to do something differently, to get somebody out, to change the way they work, are available in the sort of management literature, but I think we all know them anyway from our own experience. It can be affected by a lack of leadership, and that's the leadership within the organisation fully supporting the aim of getting people out, and that could be transforming care, the NHS plan, and leaders should be setting goals and monitoring what's going on. There can sometimes be a lack of support from managers and colleagues, and we'll come on to that later. There can be a perceived increase in workload. Sometimes it is just easier to carry on doing what you're doing than have to do something that may be more difficult. And again, I'm not saying everybody, but I think we've all been in enough places to say that this might be an issue. Sometimes, I've mentioned it before, there can be a lack of skills and knowledge among professionals. And I think if we don't really think we know exactly what we're doing, then it's better for everyone if we say, I don't really know this, I need to go and learn it, can somebody help me? As opposed to sort of saying, I'll do this instead. There can be a lack of confidence in an ability to deliver. Are we sure we're going to be able to do this? Sometimes people could feel that the decision to discharge this person has been imposed on them. It's come from on high, it's come from NHS England. I don't think it's right. Teamwork doesn't always work. There's a lot of staff turnover. Sometimes there can be a culture of blame. Well, he's like this because of that. And I have to say also that job satisfaction, which is often lowest amongst the lowest paid and least qualified, can also make it hard to introduce change. So if you've got a large group of people who are not paid very well, not qualified, not getting a lot of support, their job satisfaction may well be not at a level of some other people in the organisation, and therefore change can be much more difficult for them. There's something just come up on my screen.
One of the participants was struggling to hear, so I've turned on the live transcript, but you can just ignore it.
Sorry, I'm not talking loud enough. Do I need to?
No, I think everyone else is saying they can hear you fine. I think it's maybe just a problem with the audio.
Okay, that's fine. So then there's issues for the individual who is placed within an organisational framework. And I want to talk about organisational motivation because I'm not sure we talk about it enough. Maybe we should. As I said, I'm doing some work at the Challenging Behaviour Foundation. And actually, this isn't definitive and it's really my thoughts as opposed to from them. But there are some possible factors that might be affecting motivation and implementation of discharge. And these are pretty much my observations. One of them is the one I've talked about, which is you want the person to get better before they move. So they've got to be ready. They've got to jump through some hoops and, you know, they've got to stop hitting people, or they've got to stop self-injuring, or they've got to be able to do this, and they can't possibly move because of that. And there aren't any appropriate services out there. And the question is, how motivated is the organisation to go out and find them or help someone develop them? If all that's said is there aren't any appropriate services out there, then okay, but actually what are we doing about it? There can be a resistance to moving the person, and that's not just because you want them to get better before they move, but actually it could be fear, because actually if you discharge someone and it all goes wrong, is there a culture of blame? That means you're going to get the blame. What's going to happen? So actually maybe it's just a bit safer for everybody if they stay where they are. And then there can be professional judgments about feasibility. People come in with all sorts of different ideas about what's reasonable for somebody who is behaving in a way that's very challenging to others, and actually just may not think it's possible and may just think they should be in a forensic service. So, you know, you really have to understand the issues of other people's thinking about what their beliefs are. Sometimes there can be resistance from the receiving community NHS specialist service, and I've certainly seen that happen sometimes. No, we haven't got the spare capacity. We know we don't want this sort of service. We don't believe in that provider. There can be all sorts of things, and that needs to be they need to be part of the plan as you start building the plan for the person. Sometimes it takes a long time for things to come back, that decisions take a long time and then they get lost and then you have to start again. So you could keep asking, you get no answer. I know that a number of services have talked to organisations or the management about what about a crisis plan that's a crash pad. And actually, so you don't need to come back into hospital if something goes wrong. There's a place you can go. And it sort of disappears into the ether. And it shouldn't. We should be really thinking about these sort of supports. There is an issue about community providers, and we've certainly come across this, and commissioners bid for people to come and provide a service. They may get 3 or 4 providers who say they're skilled in working with people with behaviours that challenge, and actually they're not. And when you start unpacking that, it's very clear they're not. And developing community providers that are skilled is really a priority, because there are some brilliant, brilliant community providers out there. And I think one of the things is sharing those skills and that knowledge, but that will come to that. And I think we also need to be able to guide and support frontline staff through the reality of working with people with complex needs. And that requires consistency and long-term involvement. And that requires the organisation to support that happening. So you have to be able to, the whole organisation, the senior people in the organisation, the managers, everybody has to be able to say, yep, that's your job. You do that because this is not easy and it's going to take a long time. But recognising that you might need a longer transition with the hospital and receiving team working more closely. And again, waiting for people to be ready for discharge won't work. But some of this requires the organisation to be motivated to give permission to do this. And I'm not sure it's either we're not asking, some places it's obvious and it happens, but in some places it doesn't. So there's a whole set of complicated things going on that I think we could usefully go to work and start thinking about, because it's quite hard to do it actually, but we could go to work and start thinking about, is that the case here? Can I do something about that there? So I thought it might be worth thinking about, what would we say if somebody raises the issue of discharge where there's resistance, and think about how might we respond? What could we do? And actually, I'm not saying, I also think that these issues can come up not when you're just raising the issue of discharge, but actually when it's being planned. Because it's, you know, things might happen while you're in the process of saying, we're setting this up, we're training people, that makes people think, I'm not sure this is going to work. So it's the process of discharge, not just setting up the plan. One of the things I've heard, and I'm sure all of you had, is X has already had lots of placement breakdowns. It's likely there'll be another one. That's the sort of a take on the we've tried it and it doesn't work model of response. And I think we could usefully ask some questions about things like that. So what do we know about the nature of the support that was offered in those placements? What support did the local service offer to prevent placement breakdown? And what can we learn from this so that we don't make those mistakes again? Because if it didn't work before, it's probably because we didn't get something right. So what can we learn from that to make sure we get it right this time? So it's an opportunity actually to really find out how we can do things better. I've also heard it's too risky, I won't authorise discharge. And maybe some of you have heard that. And I think we have to challenge that in terms of, well, what is the risk? How has it been assessed? How is it being managed currently? Has it properly been addressed in the PBS plan and implemented? And actually, have you considered X's legal rights in this and their human rights? You can't just say it's too risky, you're never going anywhere. There's got to be, this person is an individual, UN Convention on Human Rights, there are risk assessment methods we can use, and there are methods we can use to manage this. So can we just try them? One you can hear also is we've done a full assessment and implemented a PBS plan, and their behaviour is still very challenging, which is another take on we've tried it and it doesn't work. And then I think you just say, well, how good is the plan and how is it being implemented? And go back to what we know about care planning and PBS planning, as it can be done. It can be done very well, but also it may not be being done very well in the service where the person is. There's now, well, we can't find a house or provider, or the house isn't suitable. Well, we need to talk to commissioners. What have they said or done? What have they been told? Because what do they really know about what the person needs? And have we really persisted with ongoing and persistent attempts to provide, to find a provider? And who's worked with them to develop a care plan and to develop staff skills and ensure that the provider is not going to be left to deal with issues by themselves? What adaptations need to be made to the house? Now, these are all sort of obvious questions, but I don't think we always answer them or ask them at the obvious time. And I'm just wondering if maybe we could start thinking about that a bit more. And I'm sure many of you are already doing this already. And as you are, then maybe more people supporting you in doing it is what we need to be getting to, because I think the change of the system will occur when enough people around the person who is in hospital say, and this is what we want to do. Okay, you might, I've heard this one as well. X is settled now since we moved him to his own separate accommodation in the ward. It would be wrong to disrupt him now. We should wait a bit. Yeah. So again, human rights. What sorts of, you know, is it right that somebody is left in separate accommodation in the ward? And you have to ask yourself, what treatment is the person getting? How long should they wait? What are we doing to help him leave his separate accommodation? In the CQC review, I came across a number of people who were in, well, in segregation, really, separate accommodation, whatever you want to call it. And I would ask, well, what are the plans to either improve their quality of life or enable them to do something more or learn some skills or find, you know, become less panic-stricken about passing this door? And often there was nothing. It felt like the treatment plan was, they're okay now, they're much less challenging. But the result of that, I remember the story, a young man who was in a hospital and he was in a room at the end of the corridor. He was autistic and he also self-injured and he shouted a lot. And clearly people had decided he may have been, it was very risky. And I did some momentary time sampling observations for an hour on this young man. And he his food was placed halfway down the corridor, and then the staff would withdraw, and then they would shout to him and say, your food's here. And he'd come down the corridor, pick it up, take it back to the room, sit down, eat it. And then they would tell him, bring your food back, and he'd put it back in the corridor in the halfway point, and then they'd go and get it when he'd gone back to his room. Now that made me think, God, is he really that dangerous? It was really quite strange. He would hide himself under things and did a lot of self-injuring and hitting himself. And staff had no consistent response to this. Some of them would say, oh, stop it. Some of them would say, are you okay? Some would ignore him. And it was clear there was no sort of sense of what does this mean for him? It was just something he did. And there was no sort of, if you like, treatment plan in place for sort of working with him on his self-injury. If you're in long-term segregation, there has to be a review every 24 hours to make sure that you should still be in long-term segregation. And if somebody's in long-term segregation for a long time, that becomes just a routine tick box. So the doctor on duty will come and say, is X still in? Does he still need to be? Yes. Is he still okay? Is he getting? So you have a form that you fill in from the Mental Health Act office, and you tick it and you put it in a box. But you don't really ask the question, what are you doing to get this person out? Which is the purpose of the 24-hour review. So we need to think about things like that happening. Okay, enough on that. X's family are unrealistic. He won't be able to live in the community like everyone else. Well, the answer to that is his family love him and want him at home. They want him to have some freedom, and they want him to be safe and well supported, including by then. And actually, we need to be seeing families as an asset, a source of support, not a problem. And too often they're seen as complainers or awkward or asking too much or not able to understand like we do. And I think we just need to be much more thoughtful about those sorts of ways of approaching families. And again, X isn't ready. His behaviour is still challenging. We need him to be less aggressive, disturbed, destructive, or whatever before he moves. And again, we need to ask ourselves, can he ever realistically ever get better in a ward environment? I think especially if you're autistic and you need sensory events to be managed in a way that you can cope with them, and you need some predictability and routine and all of those things, and you don't need millions of people surging around you, then you are going to be in a constant state of anxiety in a ward, and you will not get better. You will get more and more distressed, and your behaviour will become more and more challenging. And that could be looked through the prism of, this place is really, really bad for X. It's really not helping him. Or it could be looked at through the prism of, X is getting more and more challenging. We need to get more and more restrictive. And we need to be thoughtful about which pathway we go down with people who are in that situation. So we should instead be asking, what environment and support does he need? And can we start planning it now so that he can move to a place that's more likely to deliver a good quality of life for him? Sorry, I'm not able to, yeah. So let's think about how can we address anything? And there is issues about if people, do we know the people who are stuck either in your service or out of area if you're in the community? Are we able to look at care plans and assess them against, for example, the PBS Academy guidance on what should be in a care plan? And that's in the CBS resource for families, I'll show you later. Can we discuss with colleagues a possibility of update or refresh? Can we really look at a discharge plan and see how does it relate to what we know about the person as an individual, and how detailed is it? Do we need more information about the person and how to support them? Maybe we should be more clear about acknowledging the difficulties of delivering a therapeutic environment in hospital with an MDT, with the MDT and ward staff, and actually not just say we're doing it wrong, but actually how do we make it better as a sort of project, if you like. Again, challenge the readiness model. And I think we need to be, maybe we could do more preparation and information and try and involve other bits of the organisation to support it. I think it's worth discussing the CQC document on the quality of life framework for inspectors, which they'll be using when they inspect learning disability wards, and actually does look at issues around what is the plan for the person? Is it person-centred? Is it individual? Is it being implemented properly? And so these questions are going to be asked much more clearly by the regulator in time to come. We do need to get to know and work with local providers. There's nothing better than just going into a provider who you know, and you can just start the conversation so much more easily about what we need to do. And again, be prepared to work with the individual and their family in the longer term. And actually, I think it's something about paying attention to the details of how support will be delivered and work with the staff to develop and deliver them. I think we can deliver training that's individually based, but actually sometimes what you need to know, in the morning when X gets up, what do we do when he gets up? How do we support him in the bathroom? And you could talk to 5 members of staff, and 5 members of staff will do it differently. Whereas actually, if you sit down with them and have a conversation, you might get 5 members of staff doing it the best way for the person, as opposed to what they think is right, and nobody's telling them not to, but actually it requires detailed work and detailed thinking. And I think being prepared for how long it takes. And I also think we need to check out our own skills, because this is not easy to do. And all of us have got varying levels of ability to do it. And I know there's loads of things I can't do, but I think we can usefully just monitor ourselves and be clear about, if I'm saying I'm not doing this, is it because I think it's not a good idea, or is it because I don't think I know how to? This is the flowchart from the Challenging Behaviour Foundation. It may be familiar to people, but it does ask a series of good questions. So do they have a functional behaviour assessment, which gives a clear understanding of the reasons why they use behaviours that challenge? Is the plan based on the functional assessment? Does it have information about the life and things that are important? Are there needs? Does it talk about their needs and how those relate to the behaviour? So I'm not going to go through it all because you can read it yourselves, but actually it's quite a helpful sort of flowchart, if you like, quite a helpful checklist, just to make sure that all those bits are in place, because often I think you'll find that from the purple bit down, called reactive strategies, is quite well in place, but the bit above may be a bit thinner. And this is the CQC quality of life framework, and they describe it, they're what they put on their website: a structured and logical set of questions our inspectors might ask and that service providers should be asking themselves. They help us understand whether the service is meeting the needs and aspirations of the people it is supporting. It points to potential sources of evidence with guidance about how to find the answers. So there's a section on, is there a planned programme that focuses on their quality of life? Are the planned programme components relevant? So you haven't got the generic, everybody does this. Are components of each person's support programme being delivered with fidelity to the right level of intensity? You can tell this was written by a behavioural practitioner, can't you? Are they delivered properly and often enough?
No wonder we make ourselves so unpopular. We just can't use proper English. Like fidelity, if anyone is in that doesn't know what that means, it just means, is it done the way it says it should be done, rather than in practice, rather than name. But behaviour analysts have this horrible reputation for needing to use big words and sound clever, and I'm as guilty as the next one. So I apologise on behalf of my field.
We could always feedback that back. And is there a balance of programme components, and are support plans for each person coherent across settings over time? So are they getting their PBS plan in more than one place? Is it in their lives everywhere, or is it just, from 9 to 5, Monday to Friday? Never would be, but you know what I mean? It's sort of, okay. So can we do anything? I am going to say there may be some actions we can take, and we could decide for yourselves, but I think there are some things that if we want to break down some of these barriers or manage them better, then there are things we could think about doing. And the first thing I'd say is talk to people who think like you do, because the worst thing you can do is try and do this alone. And certainly the work that the CBF is doing, if we go into a service, we don't go in alone, we go in as a group of 3, because actually, apart from that, you bring different things, you actually are much more liable to be able to manage what's coming at you if there's more than one person trying to do this. I think we need to be thoughtful and considerate the person's family and how we can work with them in a much more detailed way, and think about their advocate as well. Have they got an advocate? Is there an advocate? What are they saying? What are they doing? So think about what's happening in terms of their plan, the plan that is supposed to be the sort of core of the treatment that they're getting. Is it up to date? Have the assessments been done? Are they being used to guide the support that the person gets? Is it being monitored and reviewed properly? Is it of good quality? I have to say, I had seen PBS plans being monitored and reviewed in MDT meetings, and you often get a sort of a graph of somebody's behaviour, or you get a graph of somebody's behaviour over a month or a year. And sometimes that's great, and it's accompanied by analysis of why that's happened, gone up or down. And sometimes it's not. Sometimes it's accompanied by guesswork. So we just need to be more thoughtful about how we tie the different bits of the work that we're doing together. And again, in some places it's working brilliantly, but I think what we're talking about is the places where it may not be, and where people are not getting the chance to be discharged as we would like them to be. We need to consider their support in terms of staff skills and their beliefs about X, about the person. It's not just what they know about PBS, but what do they believe about this person's possibilities, if you like? What do they know and understand about their needs? What do they know and understand about PBS and how assessments relate to supporting them? And what support and guidance are they getting? And how is their stress being managed? This stuff is not easy. And we need to pay as much attention to how we're supporting people doing the support as we do to thinking about the plan. I think we need to consider MDT support for actively pursuing discharge. And I think this varies from place to place. So, but it is reasonable to ask, how is their current care plan reviewed and modified on the basis of the knowledge? Is there a discharge plan that's being monitored closely and with goals attached? And has the MDT based the discharge plan on good assessment and formulation? Do they talk to the local authority or commissioner? Do they have regular meetings? Are they chasing? And is the CUTR effective? And then again, senior management support for actively pursuing discharge. Is it regularly discussed? Are there cross-agency meetings? Are goals set and monitored? Are problems discussed and addressed in a timely way? And do they know about the CQC quality of life framework? Because actually, when the inspectors, having done a lot of inspecting, actually, if you ask people, are you adhering to the, at one time it was Chloe's, the quality of life framework will become important if it's implemented, that because people will be asked questions about it, and maybe we should start talking about it fairly soon. So let's think about this. This is patient A, still in hospital, still in his 423 square foot apartment. But interestingly, the barriers that were keeping him in place have been broken down, really. And they've been broken down because newspapers and the television services got involved. So those barriers were overcome by media and by publicity. And actually, we don't really want that to be the only answer, do we? But we can go from this to Bethany, to this, on her 21st birthday, living in the community.
I mean, what a champion. Would you just look at that? That at my 21st birthday was not that good.
But you know what? The picture says it all, doesn't it? Picture's worth 1,000 words. If I try to say, Bethany's out now having a good life, yeah, okay, but actually that's Bethany. So there are lots of issues and barriers, but actually when we do it right, people's lives get better.
Yeah.
Thank you.
Oh, bless you, Theresa. Thank you so much for that. Very thought-provoking, and you and I have had conversations around this before, so it's not a surprise to me that you have some of these insights into the services that you have worked with. And I've made some notes because I think obviously we've got a little bit of time for questions, and I would love for people to ask you questions, but if not, I will use the time to ask you questions. So guys, jump in, or all you're going to hear is my particular thoughts. But I wrote like so many bits. I think the first bit you said that made me not like wry smile, like not smile with happy, but like was the section 2 and 3, the section for assessment and treatment. And I obviously will put out a disclaimer there that says there are some amazing teams out there who really help people, and I am so grateful they exist. And I completely agree with you on the point of we can't just be getting rid of inpatient units. Like, nobody's saying that they're not needed for anyone, but I think there is a lot of work to be done around getting clear on what that assessment and treatment means for people, particularly those with autism, who are there because their behaviour is a concern. Because very often I'm not clear what that assessment is or what that treatment is, and they've been there for 2 years, and that's exactly what you said. And I think, how do we challenge that? How do we say, but there is no treatment? There is no there's containment. That is a more appropriate word, without completely breaking down the relationship that you need to have with that institution or facility in order to have a chance at giving this person a better life. So I walk this tightrope sometimes where I think what I want to say, what my heart wants to say is, I cannot see that you are doing what needs to be done for this person. But what my head is saying is, if you make them hate you, you can't help.
Mm-hmm.
And navigating that is so hard. So one of the questions that came up is sort of generally around who is best placed to challenge these things, like who is in the best position to frontier these arguments. And is it the person's advocate? Is it a lawyer? Is it all of us? Is it a universal thing?
I think it's all of us, actually. I mean, there are cases that I've been involved in where it's been a lawyer. And that, I think if you're at the point where you have to go to court to sort this out, then things are pretty bad in a way. There's a lot of division, because it means you only go to court because people can't agree on what should happen. You don't go when everyone's agreeing. There's huge disagreement, and people have got very strongly held views. And people will have strongly held views now. And I think you're right, because it feels very difficult to challenge. And that's why I don't think we should ever challenge alone. Sometimes it's about having conversations, because the thing at the beginning was about no such thing as a dysfunctional organisation. Actually, the way out of that is to start building coalitions with other people. So who thinks like you do? And then I don't think it's a case of saying you're doing this really badly, it's awful. I think there's a case for saying, I found out about this, could we try this? What about this? This is the way, I'm just looking at the care plan thinking, can we improve it like this? Do you see what I mean? It's sort of, how can we go forward rather than like what you've done looking back? And it will take time, and there will be resistance, because if we start asking questions, and that's why I say don't do it alone, if questions start being asked, then all the issues that I said about resistance will come up.
Yeah.
But actually, that means you have to talk at different levels of the organisation as well, not just to one bit of it.
Because there is that thing, I think, and I could be reading into this a little bit, but sometimes I have felt like people believe they've tried everything. I don't, like you said, I don't think they're lying to us. They're not conspiring with one another to keep individuals in hospital. Although I think the organizational motivations of a lot of the private equity hospitals are a barrier, because it's screwy to me that they get paid if they don't manage to do what they're supposed to be doing. You know, if I treat you and you get better and we discharge you, we stop receiving income, which is just a screwy set of contingencies in behavioral analytics speak. For
incentive.
Yeah, it's a perverse incentive, exactly. And I can't remember where I first heard that term. I think it might have been Sandy that said it to me. And I was like, yes, that is exactly the right thing. So obviously there are situations where that's the case, but very often I don't think that people are conspiring to keep individuals in inpatient settings. I think they genuinely believe, we've tried this, we've tried that, we've tried this. And then there's almost this, like, if you come in or we discharge to you and you manage it, that means we're not any good.
Yeah. Or we were wrong to say they couldn't leave.
Yeah. And that there's a degree of defensiveness develops around, maybe not consciously, maybe it's a subconscious thing, but almost around being afraid to be shown up as not as effective as we'd like to be.
I think there's a whole host of things that go on. I think sometimes people feel hopeless. Actually, there isn't anything we can do, and have no optimism, if you like. Sometimes people feel just ground down. Sometimes people think it won't ever work. Everyone, there's a whole host of categories of reasons, if you like, about why things aren't changing. And I suppose if nothing else, that's sort of part of what I'm trying to say is maybe we all need to get a bit more analytical about what those categories are in the services in which we work. Because if we don't start recognizing them, then we're never going to be able to do anything about them. Yes. And that's the first step. Let's just start recognizing them. And actually, once we start recognizing them, I think we will start thinking, well, what can I do about it? Because that's the reason, the sort of jobs we're in, we sort of think, what can I do about it? And that is not an easy thing to do. But, I think, like everybody else, I don't want to be in a situation where patient A has to wait for Ian Birrell and BBC and Sky News to have any chance of getting out of hospital, or for Tony Hickmott to have to wait 20 years because it was possible to just forget about him.
Yeah.
So yeah,
there was a question from one of the audience, which is, how do you think we can support commissioners to think more creatively and not try to do the box slotty thing where we've got, I hate that term, voids, like there are void, it makes me think of a black hole, the guy that we're going to situate in this void is going to disappear into the ether somewhere. But you know, it's the language that's used, I think, sometimes. So how do we encourage commissioners not to go down that route of here's what's available, square peg round hole, but to think more creatively? Any thoughts, Theresa?
I think one thing is to talk to them about it, because actually I think the one thing we do know is if you fit people who have complex needs or behaviour challenge into a service, then you might end up in more of a mess than you started. So it's not always a good decision. But actually, I think if you're going to say that to somebody, you have to have good understanding and reason to be able to explain to them and talk to them about why that is, and offer an alternative and say, but actually, we do know that this works, because we do know that this works. A different model does work. Yeah. And actually, and sometimes I think we need to spend more time talking with people about what we can do to help them do things differently, in a way. And sometimes I think that's quite difficult to do when everybody's very busy. Yes. But if you don't start doing that, then another story about, I was one tribunal I was at, and the commissioner had commissioned, anyway, I think it was a 14 or 15 bedded autistic unit. And, you know, I gave evidence and said, well, you can't fit everybody in the living area. What are you going to do? How are you going to manage routine? All sorts of stuff. Anyway, he said, look, I know it's wrong. I know it's not right, but I had to do it because I just got to get these people out. And he stood up in the tribunal and admitted that he was being pretty much forced into doing this. And I thought, you can't not acknowledge that. That's a reality. But actually also, he said, I would have liked to do something different. And I thought, if at that point somebody had said, and you can, and this is how we'll do it, and I'll help you, so you don't have to worry about X, Y, or Z, because I've got a plan, the discharge plan says this is how we'll do it, then actually that might not have happened, and it would have saved everybody a lot of anxiety and money. But we need, it's not enough to just say, don't do that. We've got to say, and do this instead, and this is how we'll do it. Because I think we all know, actually, we've all got a pretty good idea about how to do this stuff. Maybe we just need to get a bit more clearer about saying it.
What I find really encouraging is how many people there are in our field who feel this way, who feel strongly that there is a better option for people and that there are, you know, mechanisms to make that work. And one of the phrases that, you know, I think we toyed with for your original title was "it can be done." And I think it was one of your colleagues, Dave, who said that first in a piece of work that we've been jointly involved in. It can be done, and he kept coming back to that phrase. And I think that we almost need to like form this movement of it can be done. And we have, clearly there are so many people who believe that strongly. We just have literally like 4 minutes. So you've had lots of comments. Someone suggested, which I thought was really nice, is that a poster should be created of your barriers to discharge that should be put up in all settings, so that if they say it at any point, like, then they're aware that they're saying this thing that's like, oh damn, I fell into it. I said he needs to be ready. Because I think that's a really nice idea, because we do hear that a lot. He's not ready yet. Not ready for what? You know, not ready. And with one person in particular that I have worked with over the past couple of years, like the setting he was staying in, the rhetoric I ended up using with the team was, he is allergic to that environment, and everybody says they'll let him go when he stops itching.
Yeah.
And it's just completely unfair. It's totally unfair to place that entire expectation and onus of behavior change on him when we all know that this place is causing him distress. But you've got to get better before we let you. You've got to cope with it. And I think if anybody in the audience has not read Alexis Quinn's novel, which bizarrely the name of which has just flown out of my head, which is very embarrassing. So someone must know. What's a Unbroken?
Unbroken.
There we go. She so much more eloquently than I would ever have a hope to, describes these issues because of her own personal experience, where she was asked to recover in an environment that was completely untherapeutic to her. So I think that that's a helpful resource when challenging some of these. Someone has asked if Bethany is the young lady with a PDA presentation of autism. I don't actually know that. Do you have? It is. She is.
Yes, she is. Yeah.
Yeah. And if so, does that demonstrate that any community placement needs to be bespoke? I think absolutely.
Yeah.
Absolutely. Whoops. And someone's commenting about the parents being listened to, which is really key. I think that, and lots of people saying it's just really relevant to them. I'm so sorry, folks, if I've missed anybody, because there was a wee flurry there at the end of people. So if I have missed any questions, if anyone has a burning question, if you send it to me, I will forward it to Theresa, and if she has time, I'm sure she would answer it for you.
Yeah.
And we will be putting, oh, someone says they're feeling really motivated. There you go, Theresa.
That's lovely. That is really lovely. Thank you.
Motivated to build the It Can Be Done movement. We're off.
Yeah, let's do it.
Let's do it. Thank you so much for giving up your very precious time to do that for us. And at some point, I promise you all, it will be as soon as I possibly can. The videos, the recordings will be uploaded onto the website along with PDF copies of the slide presentations, if anybody's wanting to see that. But I think a couple of those resources are also available on the CBF website. Am I right?
Yes, the flowchart is.
The flowchart, which is a really good one.
One is on the CQC website, and it's part of the latest update on Out of Sight. So you'll find it somewhere there.
Brill. All right. In that case, thank you so much and have a wonderful day.
Okay. Thanks very much, everyone.
Take care, Theresa. Bye-bye.
Bye. Bye.